I have a pearl for your clear aligner treatments that I think will be helpful. I think we can all agree that your goal in clear aligner treatment is to keep the teeth inside the aligner by whatever means you can. And hopefully that's going to be with patient compliance and a good digital plan. But there are times if your case is not tracking, maybe it was patient compliance, but it could have been something about your plan. And one movement that's challenging for aligners are movements with a vertical extrusive component. And if that movement does not play out, you're going to have a situation where you're going to have the aligner at a certain vertical level, but if the teeth didn't follow, you're going to have a gap in the tray. So if you have a situation where a patient comes in, and let's say it's a lateral incisor, and you're trying to extrude that tooth, you'll have a gap in the tray where the patient will notice this sort of space and think the aligner isn't fitting well in that area, and it's not. And how do you handle that? You maybe are familiar with a technique called the bootstrap technique, which is a little bit difficult. Patients don't love it, where you're putting vertical elastics from buttons on the buccal and lingual to try to extrude the tooth down into the aligner. Now you can do refinement and put an attachment on the buccal surface or a different attachment if you used one originally to try to bring that tooth down. So there are different things you can do, but I have a pearl that can be very helpful to address a couple of aspects of the treatment and the overall case. Here we have a before and after case of a situation that included a lateral incisor that was in crossbite. And so basically, I want you to look at the length of the clinical crown in the finished position. This is the finished result, and in the beginning. And you notice the difference in the height of the tooth. So basically, the ClinCheck involved a buccal movement of that tooth. But what you really will see with aligner treatment, kind of like a round wire, you'll see a tipping, which will lead on that fulcrum to a lifting of the incisal edge, a raising of the gingival margin. And that is not accounted for in this ClinCheck. This ClinCheck was ambitious, especially without an attachment, to try to bring that tooth out and then give it some vertical overlap or some overjet to stabilize it. But that didn't happen. What happened is the aligner was shaped exactly like you see here at stage 33, but the tooth inside that was shorter than the mark. Now, you can focus on some sort of refinement or techniques to bring the tooth down, but at the end of the day, this plan actually probably wasn't ideal because the patient has a high lip line and you can see the gingival architecture has a step. The problem here is the shortness of the clinical crown. So again, what I did chairside, and you can do this at the end of all the aligners before maybe a retainer, or if you're going to do refinement, or you can do this midway if you want to improve tracking of the remaining aligners, is I basically took the tray, which was demarcated here. The incisal edge of the tooth was here. And so I prepped and beveled the tooth, filled the tray with bonding material, usually an A2 shade is a good universal, and then cured it, peeled it off, cleaned off the excess, and here's the tooth after the bonding. And then basically you then can even have the patient leave this in place at the end of the treatment, tell them maybe to get it switched out by their general dentist if it's not perfect. But this is a great technique, not just to finish up an aligner treatment, but to lengthen a worn tooth to help you have an extension to give you a better mechanical fulcrum to continue the remaining movements.